So good day, good morning, good evening, good afternoon to everyone participating in our ISSM webinar on BDSM in clinical context guidelines for professionals. First of all, I would thank everyone participating and also thank you, the Education Committee of the ISSM, and especially our web director, Patricia Pasquale, for organizing these very exciting webinars every month. For those of you who do not know me, my name is Annamaria Giraldi. I'm the president of the ISSM. And I just want to share with you that maybe you're not a member and do not know what ISSM is, but we have a vision in the International Society for Sexual Medicine. And that is that every human being has the right to a healthy and satisfying sexual life. The ISSM, the next slide. So the ISSM was founded in 1982, and we will have our next annual meeting in October in Miami, and I really hope to see you there. Because our mission is to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publication, research finding, online and in-person opportunities for knowledge exchange worldwide. And our webinars are one way that we can educate and meet each other and discuss the clinical practice and research in sexual medicine, but also we will meet in Miami in October and see each other and continue the discussion about research and clinical work. The next. So the ISSM is built by our regional societies, and we have regional societies in North America, in South America, in the Middle East, in Europe, in the South Asian region and the Asian Pacific region. And we also are affiliated with the International Society for the Study of Women of Sexual Health. And we also have the African Society for Sexual Medicine, which is not affiliated but exists. So this is just to say that the ISSM covers members from all over the world, and I'm sure that many of you will be from different parts of the world, and usually we have representation from most continents at these webinars. The next slide. One of the benefits to be a member of our society is that we have 4 different journals. We have a video journal of prosthetic surgery, which is very much focused on urology. But then we have our Journal of Sexual Medicine Open Access, and Sexual Medicine Reviews. And if you're a member, you will have access to all these great journals where we have presentations of the highest standard of research in sexual medicine. Next slide. So having said this, it's a pleasure to invite our moderator, Peleg Sagy from Israel. She has kindly accepted to be the moderator for this webinar. Tal is a PhD and clinical psychologist in Israel. She's a sex therapist and also serves as chair of the scientific committee of the Israeli Society for Sex Therapy. She's a lecturer of the Ben-Gurion University of Negev in both the Department of Psychology and also at the School of Medicine. And also she teaches at many programs in sex therapy in Israel. She's a trained therapist of couples, emotional focus therapy, and acceptance and commitment therapy. So you're a very, very busy woman, Tal. So it's a pleasure and honor to have you here. And thank you for taking time in your very busy schedule to moderate our webinar. Welcome.
Thank you, Annamaria. Next slide, please. So good evening or good morning to all of you. And I'm very proud to be here from the south of Israel, moderating the current ISSM webinar. As a therapist, I have a great passion about the BDSM world, and I hope that after today, all of you will share my fascination with this world. So the program of this webinar, the first speaker will be Dr. Charles Moser. He will talk about what every therapist and healthcare provider should know about BDSM. Then we will have Goran Arbanas from Croatia. He will speak, Dr. Goran Arbanas, he will speak about BDSM, paraphilia, or sexual orientation. And then we will go straight to a question and answers session. Please, next slide. So how will the question and answers go? we would ask you to submit your questions on the Q&A button. This is you can see how the button looks, and not via the chat, because we will collect the questions from the Q&A section. Please be sure to add the name of the speaker to whom you are addressing the question, the question that you're asking. The Q&A session will start right after the presentations. Next slide, please. So let's start. I would like to introduce Charles Moser. He's a PhD and an MD. Is board certified in international medicine by the American Board of Internal Medicine. Is board certified by the American Academy of HIV Medicine, a fellow of the European Committee of Sexual Medicine, and a certified provider by the World Professional Association for Transgender Health. Currently is affiliated with Sutter Pacific Medical Foundation, where he practices internal medicine and sexual medicine. He's president of the Diverse Sexualities Research and Education Institute. He has authored or co-authored over 90 scientific papers or books. Charles, it's a great pleasure to have you.
Thank you very much. And it's a great pleasure to be here and talk about BDSM, something that I've been studying my entire professional career.
I just interrupt you. Just turn on your camera, please, before I turn on and give you the pleasure.
Okay. Next slide, please. So many people really don't know what BDSM is, so that's what the initialism stands for. And people often confuse BDSM and violence. So I have this concept that the difference between sex and rape is consent, and the difference between BDSM and violence is consent, that if it's not consensual, it's not BDSM. And I will sometimes say kink instead of BDSM. It flows a bit better sometimes. Next. So BDSM is an umbrella term. I'll let you read all of this. It's interesting that it has evolved over the time. When I first started studying BDSM, there was the BD community and the SM community, and they both said, we're not like the others. And in fact, over time, they realized they had a lot more in common than difference. Unfortunately, BDSM is still stigmatized, and people involved often lose jobs, lose families, lose access to children, and this obviously can affect the individual's health and well-being. Nevertheless, kink has incredible positive experiences for the individual, and while it may be therapeutic, it is not therapy. And I want to absolutely emphasize that BDSM is not a response to trauma or abuse. This is often confused by many healthcare providers. Next. It is surprisingly common. Often people have fantasies. Many people at least try it. Some people do it on a regular basis. And some people even self-identify as BDSM practitioners. There is a debate, which Goran will talk about, of whether it's just a sexual interest or a paraphilia itself. Next. BDSM, or sexual sadism and sexual masochism, have been, in essence, in all versions of the DSM, Diagnostic and Statistical Manual of the American Psychiatric Association, and in the International Classification of Diseases. Overwhelmingly, it is used only in forensic situations. As you can see, almost 500 million office visits in the United States, no diagnoses were made. What is often ignored by the American Psychiatric Association is that these paraphilias, difference between a paraphilia and a paraphilic disorder is that a paraphilic disorder has distress or dysfunction related to it. A paraphilia is just what the behavior is. Sexual sadism and sexual masochism do not satisfy the new definition of a paraphilia, and that definition of a paraphilic disorder doesn't satisfy the new definition of a mental disorder. Despite pointing this out numerous times, the editors of the DSM have not changed or fixed that confusion. Next. BDSM people, because it's so common, often present to physicians or psychiatrists or psychologists, and it becomes known that they're into BDSM, and many physicians or therapists think that whatever the problem is, it was caused by the kink, all right? It may not be the result of the kink. The problem may be the result of the kink. People who are stressed, who are being discriminated against, they have a problem, but that doesn't necessarily mean it's the result of, it's the kink itself. And the kink rarely comes from the problem. They may not be related at all, and changing how the person is expressing their sexual interests may mitigate the problem. Often we do this in therapy, and treatment may affect how the kink is expressed. Next. There's a concept, at least in the United States, about internalized stigma. And BDSM people often have feelings that they are being discriminated against, that they have they're being oppressed, and that is not evidence of a mental disorder. Again, BDSM is not violence, it's consensual. Now, just because you're into BDSM does not mean you're immune from intimate partner violence or domestic violence. They can coexist. It does need to be assessed, but the assessment needs to be kink informed to find out how to intercede. And again, all these relationships and fantasies behaviors do not indicate the presence of psychopathology, a mental disorder, or especially an inability of the individuals to control their behavior. Next. The unfortunate thing is, because most of us have not studied BDSM in school, had BDSM patients present to us and discussed it in supervision, clinicians often make judgments, and they make judgments not based on the science, which is considerable, but based on their own values. And so we all have biases. Maybe it's something's wrong, can't put my finger on it. It's always wrong to hit somebody or hurt somebody. This can't be right. It just seems wrong to me. I don't know why I want to do this. And then I see this a lot. People will say, it's okay, as long as it doesn't go too far, as long as no skin is broken, as long as there's no permanent injury, as long as it goes away within the redness or whatever goes away within a couple of hours of stopping. These are value judgments that actually have no basis in the research, from the research. Next. So this is a very short presentation. BDSM is common. Normal is in quotes because normal is a statistical normal. But again, if you're going to say something is sick or abnormal, then you should have data to support that. There is essentially no data in the literature to support that. It doesn't fit the definitions of a mental disorder. The problems are not caused or related. The assumption that the problems are caused or related to BDSM interest appears to be wrong. Imagine if we went back 50, 100 years and there was discrimination against gay people. Many of them were arrested or harassed. They had problems. It wasn't related to being gay. It was related to the person's experience in their own society. And even when patients come in and say, I don't know why I want to do this, I want to stop, very few actually want to change. Most important, we know this from other sexual interests, reparative therapy does not work. Get supervision and educate yourself. Next. And I'll stop here. I hope to answer questions in after Goran's presentation. And thank you very much. Bye.
Thank you very much, Dr. Moser. I will hand the questions for you later. You already have a few questions. And I would like to introduce our next speaker, Dr. Goran Arbanas. He's a psychiatrist and a forensic psychiatrist, a psychotherapist, and a sexual therapist. He works with both individuals and couples with sexual problems, but also as a forensic court expert in cases of sexual violence, mainly with perpetrators. He's the editor of the Croatian translation of the DSM, the 5th DSM. Please, Goran.
Thank you very much for the invitation, and good morning, good evening, good day to everybody listening. And I will expand on the talk of Charles Moser, who just introduced some terms, and I will try to get into make a point about whether BDSM is a paraphilia or maybe a sexual orientation or even maybe something else. Please, next slide. So as Charles said, there is a difference between paraphilia and paraphilic disorder, and the definitions in DSM and ICD are the following. So in DSM, it is said that paraphilic disorder should cause distress or impairment to the individual or entails personal harm or risk of harm to others. Whereas in ICD 11, they say that it involves others who are unwilling or unable to consent or is associated with marked distress or a significant risk of injury or death. So as you can see, there should be either a strong distress and impairment and harm to other people and non-consent to diagnose something as a paraphilia or a paraphilic disorder. Next, please. As Charles said, the prevalence of BDSM is enormous. So mild forms of BDSM are seen in many people. Some research show that up to 70% of people say they have some BDSM fantasies. Almost half of the questioned people said they engaged at least in one BDSM activity during their lifetime. 7.6% people self-identify as BDSM practitioners, and around 1% have regular BDSM activities. There are some gender differences, and men do participate in BDSM activities more often than women. And there are some differences according to the literature in regards to sexual orientation. So BDSM activities are the most prevalent in bisexual people, then homosexual, and then heterosexual. Next, please. How is defined a normative or non-paraphilic sexual interest? It is defined in DSM-5 as an interest in genital stimulation or preparatory fondling with phenotypically normal, physically mature, consenting human partner. This is a long definition, and it once again underlines the consensual part of sexual interactions with people. In DSM-5, there are two paraphilic disorders that can be related or can be misunderstood as BDSM, and these are sexual masochism disorder and sexual sadism disorder. But BDSM is not one or the other. Next, please. In ICD-11, it is said that only coercive sexual sadism disorder is a paraphilic disorder. So only when there is coercion, when there is no consent, then we can diagnose sexual sadism disorder. But on the other hand, there is a definition of a paraphilic disorder in general, stating that you can diagnose a paraphilic disorder if there is a significant risk of injury or death, either to the individual, him or herself, or to the partner. And they specifically list here asphyxophilia. So if we introduce this concept of definition, then sometimes maybe we can diagnose the paraphilic disorder because there might be a significant risk of injury or death. So if you are reading both DSM-5 and ICD-11, as Charles nicely said, there is really a nosology mess and confusion. So sometimes we are not sure whether to diagnose something or not. Next, please. In BDSM, there is mutually agreed upon behavior for mutual pleasure. So there is a consent, and therefore it should not be diagnosed as a paraphilic disorder. And if we look at other aspects of our life, also sport sometimes includes harm or can lead to injuries. For example, many professional people engaged in professional sport have many health issues, but nobody considers sport as a mental disorder or any other type of a disorder. Also, research shows that physical activities accompanied by pain can lead to a euphoric state, and many research have been done with long-distance running. Nevertheless, nobody says that long-distance running is a diagnosis. So in the same manner, BDSM, although it can be accompanied by pain, cannot be diagnosed as a disorder because of this simple issue. Go on, please. And I think that BDSM is more than just a sexual aspect of life, because 99% of BDSM participants state that it is a pleasurable or enjoyment activity for them. 94% of participants said they enjoy it for itself, not just for the sexual aspects of it. And in 91% of people, they say it reduces stress or relaxes. So my question is it maybe like skiing or photography or any other leisure activity? Is it possible that BDSM is just a form of a lifestyle or a kind of a leisure activity and not related to sexuality exclusively? Next, please. The question is, can BDSM have other psychological or emotional causes and not just sexual? Is it a form of identity and not just sexuality? For example, 91% of people said that it allows them to use their personal skills, and the same number of people said it is a form of self-expression or exploration. So possible benefits from BDSM apart from sex can be pleasure, enjoyment, fun, personal growth, and escape from demands of everyday life. Next. Also, when we compared BDSM practitioners and people who have BDSM fantasies with sex offenders, we can find a long list of differences among them. So for example, sex offenders mainly have very low empathy. On the other side, BDSM practitioners and BDSM, those people who have BDSM fantasies, have normal levels of empathy. It is the same with psychopathy. In sex offenders, psychopathy is increased. In BDSM practitioners, it is not. Sex offenders very often accept the rape myths, whereas BDSM practitioners do not. There are some similarities between sex offenders and BDSM, but which are not very important. And these are, for example, high levels of boredom in both groups and a higher level of externalization traits in both groups. But if we look at the most important aspects, then we can see that BDSM practitioners have nothing in common with sex offenders, and we should appreciate this. Next, please. But on the other hand, we know there is a higher rate of suicide among BDSM practitioners. Some research say that 12% of these people have previous attempts. There is a higher rate of borderline personality disorder and narcissism, but in relation to borderline personality disorder, we should check the diagnostic criteria, so maybe there is also a mess for this. And there is a higher rate of sexual child abuse, although, as Charles said, childhood sexual abuse is not the cause of BDSM. Next, please. So I highlighted only two take-home messages. One is that harm and non-consent are distinctive characteristics of paraphilic disorders, and you should keep this in mind. And that BDSM in many people is not just a sexual experience, but much more, and it involves other aspects of life for them. Next, please. So my first question from the title, is BDSM a paraphilia or a sexual orientation? I cannot answer this question, but I believe it is much more. It is maybe a kind of lifestyle, or it is a part of a personality of a person. But I think it is up to everybody of you to answer the question what BDSM is. Thank you very much.
Thank you very much, Goran. That was really interesting. And we will move now to the question and answers. Please submit your question and your questions in the Q&A button that you have here in Zoom, and not via the chat, so I can hand it to the speakers. And please be sure to add the name of the speaker to whom you are addressing the question to your the question that you're asking. So, first question, please. Well, it's not noted the name of the speaker, so we will start with you, Dr. Moser. Is BDSM becoming more common? Is it an indicator of more dangerous sexual behaviors that are common? Please unmute yourself. Yes.
I actually don't think it's becoming more common. I think the culture has allowed more people to identify with their BDSM interest. And so you hear people either talking about it, talking about with their partners, and maybe even trying the behavior.
Goran, would you like to add to this question? Is BDSM becoming more common?
Yes, I agree with Charles. I don't think it becomes more, there is an increase in frequency, but maybe in modern times we have more possibilities to express ourselves and to find material we are looking for. And it is not just BDSM related, but any sexual preferences or any other life things we like to do. So now we can find everything on the internet, and it is more easily accessible. So it is more visible, I would say, but for everything, not just BDSM.
Thank you very much. This is to you, Dr. Moser. In one of your first slides, you say it doesn't have a negative effect on parenting. And I
didn't hear that. Can you repeat what you just said?
You said in one of your slides that it doesn't have a bad negative effect on parenting, but the man who asked the question, the woman, heard of a couple who did BDSM 24/7, and the man was the dominant and the woman was the submissive, and she used to call him yes sir in front of everybody, and yes boss. also in front of their children. And she would say that this can impact children, especially as they do not know the rules and the agreements between the father and the mother. What do you think? The children didn't reach puberty yet.
Well, I first of all, because the woman said, sir, doesn't necessarily mean anything as far as the children's development. We have lots of cases of kids who grew up in a BDSM household and who decided that was not for them, or that they decided they were going to do something, a different role, a different way of expressing it. And I have yet to find a study that shows that the BDSM parents produce more problems with their children when they reach adulthood. By the way, this was a similar thing that we said, it must be two gay men or two gay women raising children is going to scar those children forever. And we now know that's not true.
Yeah. Okay, thank you very much. This is for both of you. Do you have advice for clinicians seeing sex workers who focus their work on BDSM, such as pro-doming? Example, how to stay safe, or any other advice?
I'm not sure I understand what.
I also not sure I understand. I guess the intent here is to speak about people who give BDSM plays as the sex work, people who do it professionally.
I actually have published a paper about BDSM professionals, and they're all over the map. Some do it because in their locale it's legal and they don't want to break local prostitution laws. Some do it because it helps them with, or not helps, it allows them to express their own innate sexuality. People do it for very many reasons. And again, while I'm not supporting prostitution necessarily, I haven't seen the problems from the BDSM professionals.
Mm-hmm. I see now that he specified his questions. Do you have any advice how to play safe, how to stay safe while doing the BDSM as a sex work or professionally?
There are many devices to do that, and there are papers about it. I'm not sure I can give a 1 minute answer, but in places where there are houses where of domination, where BDSM happens, there's an elaborate way to call for help from the workers, for the workers.
Thank you. Well, Ness, if we haven't answered your question, what you meant, please feel free to specify it for us. I'll specify it for Dr. Moser. Okay, so let's see, next question. To both speakers, would you say that cock holding is part of BDSM? When low self-esteem is part of the struggle the client is having, would you tend to see it as a pathology then, as a paraphilic disorder? Let's start with the first one, please. Would you say that cock holding is a part of the BDSM, Dr. Moser?
Well, obviously it is for some. I'm not sure that we can make a blanket statement. Just in case people don't know, there are people who are interested in seeing their partner with other partners. Sometimes that's part of humiliation and it has a BDSM component, but sometimes it's another interest, and humiliation is not part of the cuckolding scene.
Mm-hmm. Goran, anything to add?
No, I agree with it. So it depends on what is the motivation, what is behind it. Is it the humiliation, the power struggle, or whatever it is? Or is it something else, in which case it would not be considered BDSM?
Okay, thank you. And to you, Goran, the second question, when low self-esteem is part of the struggle the client is having, would you tend to see it as a pathology then, a paraphilic disorder?
So if it is consensual and both partners agreed to participate in it, it would not be considered as a paraphilic disorder in any situation, unless one of the partners is coerced into it. But that is the only situation when I think I would consider it a paraphilic disorder. Otherwise, no. And in many so-called normal relationship, we also have this power imbalance, and it is not a sign of a paraphilic disorder. It is just a sign of any other power inequalities in a couple, not just related to sex, but to all other aspects of their mutual life. For example, in parenting, many parents are not equal in their rights to educate their children or to have an influence on their children. It is not a pathology.
Charles, would you like to add anything to this?
No, I agree with Goran completely.
Okay, thank you. This is for both of you. Does pornography play a vital role in development of BDSM in a person? Charles, would you start?
In many cases, we see people who have interest in BDSM before ever seeing any pornography. Nevertheless, there are people who, when they see the pornography, go, whoa, that's what I want to do, and it begins the developmental process of exploring.
Goran, would you like to add to this?
Yeah, I completely agree. I think this is the question of what is the first, the hen or the egg. So we actually don't know how normal sexuality develops in all the details, and even less we know about non-paraphilic or non-normophilic sex interests. How do they actually evolve?
Yeah. And I agree that people sometimes recognize themselves in pornography. It's not an idea that it gives them, but a recognition. They identify with what they see because it was already there.
Yes, I think that we are looking on the internet what we like. So we are searching for something, we are writing some words. We will not write something that we are not interested in. As you introduced me, I work a lot with sex offenders, and sometimes I tease them because they say, oh, I just popped on something, some child pornography or whatever. And then I ask them, how many videos of knitting do you have on your computer? And then they're puzzled, and I say, but if you just by chance come to see it, then you must have some knitting videos also. Of course they don't. They have only those that they are interested in.
Yeah, I agree with you. For you, Goran, isn't it moralistic to consider a voluntary sexual activity as paraphilic because of health risk? Or should we qualify the sport like boxing as paraphilic? You talked about it.
Well, I will answer personally, because in ICD-11 it is defined this way, but also in DSM-5. Personally, I think it is moralistic, because I think that scientifically speaking, there shouldn't be legal aspects in a diagnosis. So medical conditions are not legal notions. So if we continue with it, then also murder is a disorder, or tax avoiding is a disorder because it is unlawful. So for me personally, it is wrong to have a criterion on moralistic aspects or lawful aspects of somebody's behavior. But it is the current state.
Thank you very much.
I agree. There's no embezzlement disorder in the DSM or ICD.
Mm-hmm. Thank you. Dr. Moser, how can we help our clients with BDSM fantasies who cannot accept themselves?
I think that the most important thing to do is connect them to other people in the BDSM world to develop a support system. And once they start seeing and talking to other people, their societally induced negative feelings seem to fade away.
I'll add to this question. What do we do with patients whose partners cannot accept their orientation? They just, they have a huge gap between themselves and their partner's orientation. What would you recommend?
Obviously, this is the time when we need really good therapists to help them define what their boundaries are, what they can accept, what they can't accept, and in some cases open the relationship, in some cases separate, and in some cases explore something that is mutually acceptable for both.
Thank you very much. Ellen, agree with Charles, and not to answer for Charles, but anecdote is not evidence in individual circumstances where kids observe sexual BDSM activities that not indicate the whole practice. Okay, this is an anecdote. Thank you very much. Does BDSM play a role in the intensity of the orgasm? Goran, would you answer that?
It might. Well, it doesn't in every person, but if BDSM activities are something that you are very much aroused with, and if it is a preferential form of your sexual fantasies or sexual activities, it can increase the level of excitement and the level of orgasm. But I think it is not continuous in a single person. So one day it can be better and the other day it cannot be so inducing as the day before. But for people for whom this is a preferential form of sexual activity, I would say yes, it helps.
I agree.
Okay. To both presenters, can you comment on the safe words? Dr. Moser, would you start?
So a safe word is a word, and often it's red, yellow, green to say stop, slow down, or keep going. Sometimes increase the intensity. Sometimes it's a word like aardvark, which is not normal in the usual environment, and it's a signal to the partner without saying no, 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 which may be part of someone's fantasy.
And I always say that I wish my students who make regular vanilla sex would have also a safe word, because sometimes communication depends upon it. Okay, thank you very much. This is from Israel. I feel like in the Eurovision. I wonder about the higher rate of suicide. Whether it is the influence of dominant discourse in society that make these BDSM practitioners feel that they are impaired because society judges them as such, and hence feel like a failure to achieve what is considered as normal. Perhaps if society changes its prejudice, BDSM practitioners will feel less distressed. What do you say, Dr. Moser?
I think that that's probably true. If we look back again 50, 100 years, there were a lot more suicides among gay people than there are today, as it's more accepted in Western countries. And if you look in countries where it's less accepted, suicide rates tend to be higher. And so I think the analogy is true for BDSM as well.
I agree. Goran, this is for you. The table that you showed us with comparison of traits, is this your study? Maybe there is an article. I'm interested in knowing more about it.
So this is not my study. There are several studies, and I can send them, or the title and the authors, maybe to ISSM, and then you can send to Older. participants, if you like.
Thank you very much. And Goran, also for you, how can we help clients with both BDSM behaviors and compulsions?
This is an interesting question because sometimes it is very difficult to differentiate whether there is an actual BDSM behavior or is it just a compulsion? As with other sexual orientations, people sometimes just have these thoughts, or they believe that they will have an impulse they have never actually participated in. So I think the first question would be for the clinician to answer whether BDSM fantasies or BDSM ideas or BDSM thoughts are just a symptom of OCD, or whether there is actually both BDSM and OCD. If it is just a symptom of OCD, I'm not talking about BDSM activities, but BDSM thoughts, BDSM ideas as a symptom of OCD. Then we should treat it as any other OCD. So people can have religious ideas or aggressive ideas or whatever. But if there is both BDSM and OCD, there is no need to treat BDSM. BDSM is not a disorder, so just treat OCD. So in both cases, just treat OCD.
If I can add, I agree completely, but OCD tends to have other things besides, in this case, BDSM. You can look for other obsessive compulsive issues in the person, and that supports the OCD diagnosis. If it's just BDSM, I'm not sure that it supports an OCD diagnosis. Could, but
and also,
again, good clinical judgment.
And also, in OCD, we look for the loop, the process, and not the content. So we will see the OCD loop, the OCD cycle that they use, the way of thinking about it.
In my clinical practice, people who have OCDs related, thoughts related to their sexuality, usually they don't engage in it. They fear they will engage. They fear they will lose somehow control. They fear they will do something that is totally not them, but they actually do not participate in the activity.
Yeah, actually participating would be an efficient things to do, and they don't do it because they fear it. This will be a very good check to do with your tendency, and they fear it. This is for both of you. Dr. Moser, I will give you the honor to answer first because of the disturbing developments in the USA. Do you think it will be more difficult for BDSM people in the future, given the conservative tendencies we see in some countries in Europe and in the USA?
Yeah, unfortunately, I do. I'm very concerned about sexual rights in all its different forms, and our Supreme Court seems to be moving radically to the right.
Dr.
Goran, will you add anything to that?
Well, I think it's very similar here in Croatia. We are a Catholic country, and all the non-normative sexual activities by many people or by some of the governmental policies are looked at as something not to participate in. So I think for many people it is very difficult situation, yes.
Yeah. Well, I'm not sure I understand this question, but let's try. Can a controller spouse lead a person to have BDSM orientation as an effective cause? Do you understand better than me? I guess the question is, can you make somebody with a BDSM orientation as his spouse? I guess this is the question, if I understand correctly.
It's actually an interesting question. And we only have anecdotes here, which are not data, but there are people who decided that they were going to get involved in BDSM to satisfy a partner, and over time that relationship ended, and the BDSM, the person who was not initially into BDSM decided they wanted to continue the activity. Whether that's an orientation or not is another story, another issue. But there are people who say, you know, this wasn't as bad as what I thought. I kind of like it. let me try, let me continue. And I don't want to give up all the friends I met along the way.
Goran, would you like to add anything?
Yeah, I totally agree. I would maybe just want to add that we know from sex research that when we engage in a activity that leads to orgasm, that kind of behavior is usually solidified, and you start to participate in it more often because you know you will have a gratifying experience in the end, and you try to just avoid those that are not enough for you to have the excitement so high.
And also we know that in sexuality you sometimes do things in order to give pleasure to your partner, and it's not your orientation, but you find it very satisfying to give another person pleasure, as long as it's not painful for you or you suffer, you enjoy his enjoyment.
Some people say that when they see that they are satisfying a partner, it is sexually arousing for them.
To both speakers, how can we expect risky BDSM to be, or when can we see BDSM as an unresponsible sexual behavior? Goran, would you start?
Well, as I said in my presentation, I think it is very similar to sports. So are we ever talking about the risks of sports? So if your spouse or yourself are into a long distance running or into boxing or whatever, there are known risks. But if you are an adult competent person, then you can weigh what the risks are and what you get from it. So you decide if you are willing to invest into it and to accept the risks.
I agree completely, and I just want to add that we sometimes, all the BDSM organizations put safety very high and training people so that they avoid some of the other problems. As a physician, I often see people with, we sometimes call flogger's shoulder or numbness in their wrist because of the ropes were too tight. Usually we can treat that, but again, better training and those problems go away.
And I'll say again that in normal sex, there are also risky behaviors, and sometimes even more because people don't communicate it in advance. And in the BDSM world, when it is done correctly, so everything is being communicated. So this is, in my opinion, less risky. Okay, thank you very much. Do you have any recommendations for professional publications for psychologists, psychotherapists? Any of you?
Many. If you Google my name, you'll find my CV. I have over 90 publications, most of them related to BDSM and paraphilias. If someone wants to email me with a specific question, I'll give them some references.
Thank you. Goran, anything to add?
No, I will transfer everybody to Charles.
Thank you. Isn't it artificial to try to trace a boundary between light coercion or pain, scratching, beating, as not kinky? This is to you, Goran.
Yes, of course it's artificial, but well, maybe we don't have to, but we have to put a line somewhere. So with any diagnosis, there are criteria, and there is always a risk that some behaviors will not be included and some others will be. For example, if you look for the criteria for depressive disorder, it is said that it has to last for at least 14 days. So if it is 13 days, that it's not depression. If it's 14, it is depression. Of course, in clinical work, it's not that way. But when writing criteria, we need some strict wording. But of course, we should apply it with critical thinking.
Thank
I
you
agree.
very much. Agree. To both speakers, is trying therapy on BDSM practitioners similar to conversion therapy? A good question, Dr. Moser.
Yeah, I don't think conversion therapy works, and now called reparative therapy. And I would recommend people not try it. And I think there's a question of whether it's ethical to even try it.
Vern?
I agree completely.
Me too, and I'll say that to work with fantasies from all kinds can be a conversion therapy, and it can be very risky because you don't give the person a replacement with fantasy. You just, you know, extinct it. So it's very risky. How can we identify intimacy, secure attachment in BDSM relationships? Is there a different pattern? Can you share papers with us? Goran, maybe you have an insight on this?
Well, I'm not familiar if there were some comparative research. I know that there are some opinions, but I'm not familiar with research on attachment patterns and differences between BDSM and non-paraphilic people. I don't know if Charles knows more.
My question is, how do we do it with non-BDSM people? How do I identify those patterns? And I think it's an analogous process of whether the people are enjoying the behavior or enjoying the relationship, and then developing an intimacy based on that.
Thank you very much. Wow, gentlemen, I hope you still have your energies because there are many questions. How can we identify, this is the one I already asked, sorry. Please address SSC as a requirement in play.
I'm sorry, say that again, please.
Please address SSC.
Oh, safe, sensual,
yeah.
Safe, sane, and consensual. That is a way that some people approach BDSM. If it's not safe, if it's, you know, people have to be able, sane, they have to be able to consent, and it has to be consensual. There's something called RAC, which is risk-aware consensual kink, which is sort of another version of this. It's a way for people to, in essence, put some guardrails on exploring the behavior.
Thank you. Goran, anything to add?
No.
Thank you. By the way, in the chat, Nas comments that Tashra has looked a little bit about attachment, the link between attachment and BDSM. So thank you very much for your comment. Dr. Moser, thank you. How do you help patients change how they express their kink, as you mentioned in your talk? Can you suggest any literature?
Well, now we're back to good therapy between the couple or the group, and say, where's the problem? What do you, and then we can say things like, oh, don't you think you should give the person some notice before you walk over and smack them on the butt? Don't you think we should ask if you're ready to start the play yet? And over time, that gets incorporated into their interactions and can be a much more pleasurable event. That's a simple example.
Is traditional childhood trainings and tabooing the sex among adolescents can cause BDSM in future orientation of person? I guess the question is, can your sexual attitudes or education as a kid or adolescent affect your orientation via BDSM? Dr. Moser?
Yeah, this is the $64 million question of how do we develop our sexual interests, and we don't, I can't explain why some people like thin people and other people like heavier people, why some want tall, some short, some different race or not a different race. We don't understand any of this. We can't explain it for BDSM either.
Goran, would you like to add anything?
Yeah, I totally agree. We don't know how we develop our sexual preferences. We don't know how we develop our other preferences. For example, I don't know why I like vanilla ice cream, but not strawberry ice cream. So we are not familiar with the development of our sexual interests. And there are many theories, but these theories are just theories that were not proved yet.
And I'll add that things can be sometimes based on your childhood and still be healthy and self-fulfilling orientations. It's not contradictory. It can be at the same time. But I noticed that you mentioned vanilla as a ice cream taste, which is risky when speaking about BDSM. We are being very judgmental about vanilla. To get back to children, if let's say the woman is in the submissive role 24/7 and the man punishes her in front of the children, either physically or verbally, you don't think this is harmful for the kids. So this is the continuation for the Dr. Moser about the parenting.
Well, first, I'm not sure how often that has actually happened. And indeed, we know that kids may not be able to understand that. And we do know that in domestic violence, the children often see the one parent assaulting the other parent, and that's not good for the kids either. Again, the BDSM community is very good about telling people that they have to separate that, and we want to be careful about assuming that people in our surroundings, adults or children, are consenting to being there.
I would like to believe that people will communicate that if parenting and also doing a 24/7 BDSM practice. For both of you, I would like to know if the professionals agree with me that there is never a BDSM situation or punishment when the hard limit words are allowed to be removed. Do you understand? I don't understand.
Mm-hmm.
Do you understand, Goran? Would you?
Yeah, I think the question was whether there is a situation when you can avoid safe words.
Mm-hmm.
So I would answer this as if there is some other kind of communication that can be a sign of your consent or non-consent, then you don't need to voice it. But there should be agreement between the people. Mm-hmm. But there should always be an agreement. There should always be a consent.
Dr. Moser, you wanted to add anything?
Yeah, there is something called consensual non-consent, mm-hmm. where the individual says, I'm giving you consent now. I don't want to have to consent. You can do what you choose whenever. And while that can be very erotic for some people, in fact, when you actually look at these relationships, those people leave, they change, that it evolves. It's not a simple, I said yes once and I never have to say yes again. It's more complicated.
And I'll add that the dominator is the dominant person can be very attentive to the submissive person, but still there will be a safe word. I mean, they can agree together not to use it and to be attentive to one another, but still they'll have it because it's a matter of trust. And if you use it, you stop. To you, Goran, how can you define intimacy in BDSM in relationship? Not talking about normality, but talking about safe, secure attachment from psychosocial therapy aspect, not from consent or not, because we can have consent, but it doesn't mean to be secure. Also, if any papers you can share with us, I appreciate. So this is again about a safe attachment style, secure attachment style.
Well, as I said earlier, I'm not familiar with any papers that compared attachment in BDSM people compared to some other population. But I think that in any population, and so in BDSM too, we can look into the way the two people or more people communicate between them, the way they have the how they decide on other things, not just sexual things in a relationship, how they communicate in front of us, what is happening in the situation of a therapeutical session, who is the dominant one in terms of speaking more or getting to a reaching decision and not giving up another person to participate. So I think that most aspects of their relationship can be seen in the therapy too. So usually I address the situation here and now and ask for any clarifications or ask for any, if this is any different in their home life. But we as therapists, we do not know what happens in their homes. We just know what is happening here in our room, in our space. And they tell us what is going on behind these doors, but we can respect that, we can believe that, but we do not know.
Dr. Moser, would you like to add anything?
No, I agree completely.
I'll add that, yeah, I think that sometimes BDSM is a way of working through insecure attachment. However, it does not replace therapy, as Dr. Moser said. It could be a good tool to practice or to train or to work through or to as an enactment, but we'll do the work in our clinic. To both of you, how can we better use BDSM experience feedback and therapy for our clients? What do you consider beneficial for our work? So do you have tips for us clinicians, Dr. Moser?
Well, first of all, I don't think we should be prescribing BDSM activities. Right? But I think that people can have a BDSM event and then it becomes a very rich area to explore in the psychotherapy room and what's going on with the couple or the person.
Mm-hmm. Dr. Goran, anything to add? Okay, thank you. We have just 4 more minutes. Let's see how much time we have for questions. Are death through autoerotic strangulations higher these days? I have experience where a client's partner died that way before they consulted me, and it was part of the BDSM general interest.
Most autoerotic asphyxia deaths are from masturbation, and there's usually some escape mechanism that didn't work. And so you see that. Now, there are people who don't understand strangulation and get caught up in the moment and do wind up killing their partner. That's an awful situation, but it's relatively rare. And we should acknowledge that it's rare, and many of the BDSM organizations try and teach how to do it at least safer, not necessarily safely. But it's not surprising, or is surprising, that many people have the fantasy of being choked.
Thank you. Dr. Gorn, would you like to add anything?
Well, no, as Charles said, it is really a rare condition. And I have data from Croatia. In all the published articles in Croatia, there were only 2 cases of death in the last 50 years. And as Charles also said, it is safer to do it with a partner because you have another person who is a safety mechanism. Because if you're doing it on your own, then if your safety mechanisms fail.
Goran is disrupted. Let's see if he comes back to us. Well, until Goran comes back, another question for you, Dr. Moser, and I think we'll finish with that. Is there fundamentally any sort of choice in what boosts our excitation?
In what was what?
Is there fundamentally any sort of choice in what boosts our excitation?
I'm not sure I understand the question, but we don't really have you know, some of us like large breasts, some like small breasts, some like chocolate, some like strawberry. I don't think we have choices in those things. It is what it is. Now, that doesn't mean we have to accept that and can't try and change it, but it doesn't mean that you'll begin to like strawberry and you'll hate chocolate if you really like chocolate and you hate strawberry to begin with.
Well, thank you very much, Dr. Moser, and also Goran, who disappeared. And I would like to go back to Annamaria.
Thank you so much. Thank you, Tal. Thank you, Charles. Thank you, Goran. I think we lost Goran. I just would like to tell you that we have been more than 130 people participating in this webinar. And I really would like to thank you, the speakers and the moderator, for making it so lively and all the questions that came from you in the audience. So thank you so much. I hope that you learned a lot. I surely did. And I think the beauty is that we have people asking all these very interesting questions and people with very different backgrounds and experience. So thank you so much to all of you. So I just want to advertise a little bit for our next webinar. It will take place on July 31, and that will be on some completely different, because that will be on endometriosis. So maybe I'll see some of you there, and I just wish you a continued good evening or day, and hope to see you at the next webinar, and thank you for being here. Take care.